disclosure statement, basically, a lot of these are, some of them are my pictures, but then a lot of them are from internet, and Radiopedia is one of the main sources. So the neuroimaging obviously involves a lot of things, but in this one we will focus on CT scan and MRI, and then in different lectures as time comes we will talk about DSA, how DSA is done. But I thought that we should just talk about a little bit of about basics of this thing. So this is Godfrey Hounsfield, and this is Alan Cormack, and they they received a Nobel Prize in 1979. This guy was both of them were sort of engineers. He was electrical engineer in Britain, and he's from South Africa. He went to USA, and it was his algorithm, mathematical algorithm that was defined that helped Godfrey Hounsfield, and the name Hounsfield units in terms of density that we see on CT scan is based on his name. And this is the first CT scan that he developed. The first CT scan that was done in I think Wimbledon, and that was back in 1971 or something like that. And then after in few years, the first CT scanner was installed in 73, and by 1980 3 million CT scans were done, and then by 1985 in just or but beginning of this century, about millions of CT scans have been done. CT scan basically changed the whole method of coming to diagnosis in neurological diseases. Before that, people will just talk about that whether this is a hemorrhage or this is a stroke or this or that, this certain sign, that certain sign. The CT scan, basically do a CT scan and that resolves it. That's it. So that's why I say that knowing the neuroimaging is more important in this day and age than the clinical exam. Clinical exam is very important, but then in neuroimaging is much more important than that. So how does the CT scan work? So we all know about X-rays, that they are radio dense, the bone radio dense, for example. You pass a X-ray and you will get a film, a shadow. So for example, I have a closed box which has 9 small squares in it, and I put some cucumber here, I put some cotton ball here, I put some lead balls over here. Obviously they are all different density, and if I shine X-ray from one side and I put a plate over here, I will get this different densities depending upon what is where. But then this won't tell us that. It will tell that this cucumber is somewhere in these three, and this one is in one of these 3 boxes, and this is one of these 3 boxes. So what I do is I take another X-ray from this angle. Now I can figure out based on this information that yes, okay, so red ball is in this box and cucumber is in this box, because I'm looking at these 2 images. So this is the simplest way that tells you that looking at a closed box from 2 different angles with X-rays can give you an idea where different densities are. And that's the same principle that is applied. Of course, the mathematical Fourier analysis that is used is much more complex. That's why they got a Nobel Prize. But then it helps. And these are one of the first few images that shows CT scan, and you can see those big pixels over here. And what happens is that in a typical CT scanner, the X-ray is delivered. A beam of X-ray is delivered from one angle. If it's just single plane, then you will get an image like this. But if it keeps on rotating around it, and then at the other end is the detector also of that X-ray beam, it picks that up. It will give you all those information, which then has to be analyzed. And in one circular motion, how many slices you get, that's what gives the name of this is a 16 slicer, this is a 128 slicer, this is 64 slicer CT scanner. So if in one go around it gives you 64 slices, which is more defined information, then it's called 64 slicer X-ray. So I know the people who are attending this are know all these things, but then there might be some who may not know this so much. So that's why I just wanted to tell you that this is a CT scan. CT scan will always show the bone as white. The blood will also come as hyperdense. So in CT scan, we talk about it as hyperdense or hypodense. So this is CSF in here in the ventricles. This is air in here in the sinus. These are hypodense. And the Hounsfield unit over here will be very low. The Hounsfield unit over on the bone will be very high. Blood, typically in acute and subacute blood, they will show us hyperdense. So this is a subdural hematoma. The epidural hematoma looks as a like a lens, and then you in contusion you have intraparenchymal uh, blood, which is showing as hyperdense signals in here. It depends how you dial that, the contrast and all that thing. In some pictures, you lose the gray white junctions. And here you can see it better in this, even better than this one, and you can start to figure out some of these structures over here. This is subarachnoid hemorrhage because the blood is in the subarachnoid space. And again, you see this ventricle, which is the temporal horn of the ventricular system. It's little dilated. And this is intracerebral hemorrhage. So this was extracerebral, this was extraaxial, it was outside, this is inside, this is contusion inside, this is outside, this is inside the brain, intraparenchymal, and there's some blood that has trickled into the ventricles, which are effaced. And here, obviously, there is no blood in here, it's just an infarct. And that's why you see it hypodense compared to hyperdense that you see blood. And this is little calcification in the when choroid plexus. So now all these patients would have different symptoms, and you would, if there was no CT scan, it will be very difficult to figure out the symptoms based on this thing. So a CT scan is worth 100 neurological exams. That's what. And if you are really very cocky, and you can say a CT scan is worth 100 neurologists. The neurologist will not like that, right? So I'm just joking. Okay, I'm sure there are neurologists over here, right? So next, coming to the MRI. So MRI. So the CT scan principle is basically electromagnetic waves that are blocked by those structures which do not let that electromagnetic wave pass, just like light. In the MRI, it depends on the magnetic field. So we know that all the charged particles have electrical field, right? And we also know that when a charge is moving, it creates a magnetic field around it. And that's why electrical current passing through a copper wire will have electrical field. And there is, we remember all those from our high school physics, that the electrical field is created around this wire. So how does an MRI work? Basically, the body is full of a lot of protons, but the protons of the water molecules, they are alone in the hydrogen, right? And they have their own spin. Now, in the magnetic field, so actually I should go back here. So let me first talk about this. So every charged particle, even if it's a proton, if it spins, it will create an electromagnetic field around it. An electromagnetic field of that charge, electromagnetic field around that charged particle can adjust it or move it around. So body is full of all these atoms, and the most common one is water, and the water molecule has 2 hydrogen atoms. Now, hydrogen atoms, they are single proton basically, right? And the behavior of that charged particle proton is used to acquire the signals, because those are the most common protons, charged particles in the body, and they are relatively free to flip around in response to magnetic fields. So here is one proton, which is being shown with a spin around this axis, and as it spins around, the one is around this axis, and one is it's on. Okay, so yeah, it starts automatically. All right. So when you give magnetic field, these protons, because of electromagnetic properties, they will align themselves in that magnetic field. Now, on top of that magnetic field, if you give an RF pulse, then it will, and that RF pulse is stronger than magnetic field, it will tip it over in the direction of that RF pulse. Now, that RF pulse, when it goes away, it leaves that proton rotating in that axis. and that these nuclei, they process giving off this RF signal, and then that will start to die off. As it dies off, because that RF pulse is gone, as it dies off, then that's called T2 relaxation. And not only that, as that happens, it starts to move back into the main magnetic field. It will realign itself, as you see over here, and this also takes its own time, and it's called T1 relaxation. So these are the basis of the T1 and T2 relaxation. And you do it multiple times, 100 times, 1,000 times. You do it, and you repeat those signals, and that signal is taken over and analyzed further. And it's not only one molecule. There are hundreds and thousands of molecules, not hundred thousand, billions of molecules, billions of protons, and the signal taken from those are then put together. And I will talk about how and the system works. So here is the big magnet around, right? That's the big magnet that gives that main field, and that aligns all these protons in that direction. And then there is this gradient coil, which gives that RF pulse. And when you hear that sound, tuck, 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 and all that thing is usually made by this one. And that's inside, this coil is inside here. So big magnet, that is all time, it's a super conductors in there, and it's cooled to 10 degrees Kelvin. That is always there, but this one is turned on when we start the MRI. And then there is an RF coil which basically receives the signals, and then so that's present further inside, and both of them are called coils. To understand this MRI, there's this book, MRI Made Easy, and this is the website. I will show it to you again. You can take picture of that. And it's this. I read this book when I was a resident, and it's a good book to read. Actually, it's a very small book. Okay, so now coming to actual MRIs. So this is our T2 weighted image, and we can get all the details. Actually, I should go to this one. So the most basic one is the T1 weighted image, and the T2 weighted image, and T1 with contrast. These are the basic images that we get. And when we do the screening MRI, we only do T2 weighted images. It's just on one plate. And actually, a study was done at AKU, which showed that this is good enough to at least tell people if there's any abnormality. Not very accurate, but then it cuts the cost significantly. So the differences between T1 and T2 is this, that remember this: the white matter is white in T1, whereas the gray matter is white in T2, right? So this is white matter, this is gray matter. So you see, this is whiter and this is grayer, whereas here it's opposite, right? So in MRI, we don't say dense, we say intense. So although this is both sort of iso intense, but this is relatively hyper intense compared to the cortex, which is relatively hypo intense. And in T2, the white matter is hypo intense compared to the gray matter, which is relatively hyper intense. And an abnormality like this, for example, an abscess over here, with liquid and necrotic material inside, it shows. Actually, this was not. I don't know. I don't remember if this was an abscess or not. This is one of my patients, probably, and it turned out to be a GBM, if I'm not wrong. So it shows this necrotic material, which is hypo-intense, and this is hyper-intense on T2. The CSF will always be hypo-intense on T1, and it will be hyper-intense on T2. The fat will be hyper-intense on T2 in both. And so remember that when you have a T1 weighted image, there is only two things that are white in the T1. One is fat, like in the skin over here, and the other one can be blood, which I'll talk later. In T2, there can be three things that can be white. One is fat, which is like over here, the fluid, which is white, and then blood in certain stages. Now in T1, the third thing that can become white or hyper intense is when you give contrast, and it takes up the contrast. That's the third thing, or the blood vessels like these over here. And so this is another picture, same, yeah, it was a GBM. So another picture, same patient, and you see this material over here. This is T2 because CSF is white. You can see in the globe also it's hyper intense, and here it's with contrast. Now the flare images, which is the third important thing for neurosurgeon and neurologists to understand in MRI, and that is fluid attenuated inversion recovery. So it's basically nothing but a T2 image, except that whatever is free fluid, that is subtracted by software arithmetically. These are the basic sequences obtained by the T2 T1 relaxation. The flare is not a basic sequence obtained. Flare is basically using a software and taking away all that signal that is coming from free fluid, which is very hyper intense. And that's why it shows black. And how do you differentiate a flare from a T1? Because the CSF is black in this and CSF is black in that one also. Because you look at the gray and white matter, right? So white matter is hypo intense, is grayer than the gray matter. So flare in T2, white matter is grayer than the gray matter, right? And you can always see this white line around this is the subependymal fluid that shows, and this is very good for in the intercellular space, any edema, you can see it much better. So you see over here, see all this whiteness that you see, that is edema. And then the contrast enhancement can show up in the flare also. So flare images also are obtained with the contrast. So you can see this without contrast, and this one is with contrast. And then there are some other sequences, diffusion varied images, and apparent diffusion coefficient and things like that, which I'm not sure if it will be Dr. Fatima who will talk about that, probably at some stroke. But we have some of the best neuroradiologists lined up to give you these lectures throughout the year. They will talk more about that. Uh, um, let's see if anything else I need to mention in this. Yeah, okay, so we'll skip. And then MR spectroscopy, probably when we come to the brain tumors, we will talk about the MR spectroscopy. But there are these are again the spectroscopic signature, looking at one voxel in an MRI and looking at the amount of choline and amount of NAA, N-acetyl aspartate, uh, versus lactate and things like that. So we will talk more in more detail about it, but enough to say over here that, for example, lactate will be high in abscess and things like that, whereas choline, because the turnover, the cells are multiplying and dying, and there's turnover of membranes, the choline, which is part of the cell membrane, is high in here. Um, and then there are these bold images. The bold images, these are used for functional MRI, and it depends on the software also. But what actually software can create much better pictures. We do have software at AQU, and there are other places in Pakistan that have this now. Um, so there's slight difference in the ferromagnetic properties of the oxyhemoglobin and deoxyhemoglobin. And the bold images, basically it's blood oxygen level dependent, bold. uh, it uses that slight difference because that part of the brain which is active is going to have little more blood supply to it, and the metabolic level activity of that part of the brain will have a different ratio of oxygenated and deoxygenated hemoglobin, and that is picked up. And this was done by a Japanese scientist, and I don't know if he got a Nobel Prize. I don't think so. But anyway, and but the original principle comes from Linus Pauling. He got no Nobel Prize, two Nobel Prizes actually, Linus Pauling. Um, so um, so that's what it uses. So here, for example, is the motor cortex, because if you're tapping your left finger, you will have this motor cortex light up over here. In some, we don't have this software about the speech one, but if speech can also light up over here. But you have to remember that these functional MRIs, they're not really very accurate, and there's a lot of fudging in there also. So you can't depend on it totally. Um, and so uh, this just shows an image where you have an infarct over here. It's a hypo intense, and whereas the infarct in a flare is hyper intense. And this is a flare because if you notice that there's a white around this subependymal area. Okay, all right, moving on. And here's another patient of mine, a 42-year-old gentleman, I think. He had a seizure, and we saw this image. So um, we have 84 participants. Now the issue is, if I can't ask questions, it will be too disruptive. But I actually, if it was a smaller class, then I could ask that, what do you see here and what do you see here? So I will just keep on talking myself. So here you see this is a T2 varied image, and there's hyperintensity over here, abnormal hyperintensity. And this is T1 varied image. This is without contrast, and this one is with contrast. How do I say this is with contrast? Because you see this sinus over here, it's taken up the contrast and it's not, right? You see the vessels over here, this dot where it's not visible over here. So this is with contrast. So this lesion is hyper intense. It does not pick up any contrast. And this is flare. So you see the white matter is darker than the gray matter, hyper intense. And here the flare, it shows the tumor is very clearly visible over here. And this is a T2 sagittal, where you see that the lesion is actually extending all the way into the corpus callosum also, and is showing some mass effect, pushing the the posterior part of the frontal lobe back over here. And this is a low grade glioma because it's not enhancing, and it has this kind of a margin, this kind of shape. The other feature that is used, and we have been using it, this probably is all over the world. This is being used for more than 20 years now. We started to use it in Pakistan in about 6-7 years ago, and now there are other centers in Pakistan that are using this diffusion tensor imaging, DTI. So the diffusion varied imaging, dependent on this simple principle, is that because of Brownian motion, the water molecules can move around, and as they move around, they jiggle around. They can give different signals, because when the RF pulse is given and then signal is obtained in the T1 and T2 relaxation, that molecule might have moved somewhere else because of that Brownian motion, right? And that's why in an edema, in infarct, there's so much swelling that Brownian motion is limited, and that is picked up. Now in DTI, in a free space, again, it's the same principle. In a free space, a water molecule is moving around, but then in those areas where there are fiber tracts, axons, it will limit its movement. So if there's a fiber tracts over here, it will limit the movement of these water molecules. So they will diffuse more in this direction than in this direction. And this is picked up. This thing is picked up by diffusion tensor imaging, the fractional anisotropy. So isotropic is basically it just moves anywhere freely in all the three axes. And isotropy is that it's limited to one axis, and that's picked up. I don't think I have time to go over this, but then it's because of this that image analysis, you can actually pick up the fiber tracts, and typically when the fiber tracts are passing laterally, left to right and right to left, they are colored as red. That is arbitrary. Because the signals obtained, you can then further process it and then color that red. Those that are passing craniocaudally, they are colored as blue, and those that are passing occipital frontal in that axis, those are colored as green. So it's a mixture of that combination that gives you this colorful image that we call as DTI, and it helps us. And you can dial it up and down to go to a particular track. Also look at that, and this also helps you. If there's a tumor, you can figure out that if that tumor or that mass lesion, if it's located next to a certain important tract, such as corticospinal tract. Okay, I'm going to just move on. Now, the blood gives a different signal. So remember, I told you that in T1 varied image, two things can be white. One can be fat, and the other is blood. Blood not in all stages. In certain stages, it will show up as white. This is subacute early intracerebral hemorrhage. This is a T1 varied image. Why? Because look, CSF is black, and the white matter is whiter than the gray matter, right? So and the blood over here, this is in early subacute stage, it shows as white. Here is a diagram, and if you want to take a picture of this, then you can, or go on the net, look at it. So this is how I remember it. This is the mnemonic. Sometimes I use the great George Washington Bridge and Oreo cookies, but this is a good mnemonic as well. And it's very easy. It be it dee bit dee baby doo doo, right? It be it dee bit dee baby doo doo. So if you say it so a few times, you will just remember it. So this is hyperacute, acute, early subacute, late subacute, and chronic. So in chronic, both of them, because of hemosiderin, they will be black. And in hyperacute, you will have initially in the T1 weighted image isointense, and B is for bright, D is for dark, and in T2 it will be bright. When it comes to BT, the early subacute, like in this one, it will be bright on T1 and dark on T2. So this is dark on T2, bright on T1, right? And why is it so? Because it depends whether the hemoglobin is in the oxyhemoglobin or deoxyhemoglobin stage, or whether it metabolizes into methemoglobin, and then finally the leftover is hemosiderin, and also depending on whether it's intracellular or extracellular. So it's a combination of these things that gives you different images. And that's why when you have a large blood clot, it may show different stages, because the metabolism of that blood clot is going through different stages over there. So don't expect to have the same kind of signal changes in subarachnoid blood, because the metabolism of blood in the subarachnoid space is going to be different than in a blood clot. But this is a general rule. If you go through hyperacute, acute, early subacute, and late subacute, you get this kind of signal changes. And what do you think is going on over here? Anybody? Well, I don't have time to really answer this one, but this is an old infarct, and it's hypointense over here. It's an encephalomalacia, and in this one, this old infarct is hyperintense because there's all fluid in there. Okay, all right. And then this another important image is, of course, the susceptibility weighted images. There is, so there is another T2 weighted image which is called gradient echo, but that's not used so much because the susceptibility weighted image is much more sensitive. So in the multiple cavernomas, for example, you can see this much better in these SWI images. And if there's some kind of a venous angioma, you can see that much better. So SWI is being used. The problem with SWI is that, and these are T2 weighted images. The problem with SWI is that that if there's any bone, the bone will cause problems at the skull base. If there's any bleeding blood over there, the signals from the bone, because it's so sensitive, it will mask the signal from the blood itself. So only when in the pure parenchymal area you can see these things, but when it comes to the edges at the skull base and things like that, it is not so helpful. All right.